So in this final part of Chapter 4, that we've been discussing different pathophysiologic states commonly encountered in the intensive care unit, and this last section is going to deal with cirrhotic endotoxemia, not an uncommon problem encountered in the intensive care unit, and is often a management nightmare. I think that the cirrhotic endotoxemia is kind of a summation of a lot of the physiology we've already discussed, and that these patients are often rather overloaded. They have poor pulmonary compliance, increased airways resistance, often from edema, low oncotic state, bronchovascular interstitial edema of the airway surrounding the airways. They often have a very poor chest wall compliance on account of massive ascites. They can commonly have problems with biventricular function. Portopulmonary hypertension can be seen. If it's an alcoholic cirrhotic, you can frequently see left ventricular cardiomyopathies. So these patients can be very, very difficult to manage acutely. And I think that this particular disease state is owed some discussion here. So the patient with anasarca secondary to cirrhosis often, like I mentioned, presents with large abdominal ascites, pulmonary congestion with or without pleural effusions. The impact on pulmonary mechanics is to reduce both the lung and chest wall compliance. And on the Campbell diagram, as we've seen, both sort of a summation of pulmonary and extrapulmonary ARDS as we discussed about in the previous section, but this leads to a leftward shift in the slope of the pulmonary compliance curve and a rightward shift in the slope of the chest wall compliance curve. So if this is your normal patient, this is the chest wall compliance curve in its resting state, that is without any activation of the muscles of respiration. Chest wall diastole, as I often call it. And this is the pulmonary elastance curve or compliance curve. Remember, elastance and compliance are simply mathematical inverses of each other, so I often use them interchangeably. And then this is volume on the y-axis, pleural pressure on the x-axis. This is zero, reference to atmosphere, so this is pressure below atmosphere, this is pressure above atmosphere. And again, as in Chapter 1, where the pulmonary elastance and chest wall elastance curves intersect, this is your functional residual capacity. So in a patient who's been brewing worsening salt and water overload in the state of cirrhosis can often present with a dramatic drop in pulmonary compliance as a lot of that fluid leaches out into the interstitium of the lungs. And as you saw, there was a reduction in the functional residual capacity, and the lung compliance curve shifts downwards. But the compliance of the total respiratory system also decreases because of a large drop in the chest wall compliance. As I mentioned, this is can be due to large abdominal ascites. So before I'm getting a little bit ahead of myself. Before moving into chest wall compliance, you can see that the drop in the lung compliance results in a larger pressure differential between in the lung and the chest wall elastance curves. That means, as I've mentioned many times before, that this lateral distance here, again, this is referring to pressure on the x-axis, this lateral distance between the static compliance curve of the lung and the static compliance of the chest wall represents the amount of pressure that must be generated by the muscles of inspiration to generate this particular volume. So in this patient, to move from functional residual capacity upwards to this new thoracic volume, well, it is this green arrow that indicates the amount of pressure that must be generated by the muscles of inspiration to achieve that volume. And you can see, comparing it to the normal state, which began this slide, that this is increased. It's further increased by this impairment in chest wall compliance. This is the large ascites. So now you can see that to achieve any given volume, the amount of pressure that must be generated by the muscles of inspiration is greatly increased. So this patient's work of breathing goes way up. And we talk all about work of breathing in Chapter 1, but in particular here, this would refer to the elastic work of breathing. That is the work of breathing dedicated simply to achieve a given thoracic volume. And we're really saying nothing about airways resistance, which would be an additional load upon the respiratory system. So as I mentioned also in Chapter 1, that when there's a large elastic load on the muscles of respiration, patients often engage in this rapid, shallow breathing. They kind of start panting. And the rapid, shallow breathing, if you're breathing instead of at this volume way up here, which requires an enormous amount of pressure, an enormous amount of work to achieve volumes this size, patients start breathing at very low volumes to minimize this elastic work of breathing. But in order to maintain adequate ventilation, they've got to greatly increase their respiratory rate. But also, as I talked about in Chapter 1, that rapid shallow breathing results in an effective increase in physiologic dead space, and you can retain carbon dioxide from that. So the functional residual capacity here is greatly reduced, and airways resistance increases, as I've already mentioned, from interstitial edema, but also breathing at small lung volumes, as I talked about in Chapter 1. At smaller lung volumes, the airways tend to collapse, so that in and of itself increases airways resistance. So if the patient starts breathing at FRC, there's an increase in the airways resistance, and again, to the left of the curve here, to the left of the pulmonary elastance curve, this additional curve represents the pleural pressure or the increased pressure that must be generated to overcome the resistance to gas flow. And that's what I've indicated here. And then on expiration, the patient may, because of high expiratory airways resistance, grunt, bear down, as I've mentioned before, increase intrathoracic pressure in order to generate that volume. So they're sort of rapidly and shallowly breathing around this loop here. So again, just to get back into this analysis of heart-lung interaction based on the juxtaposition of the Campbell and Gaytan analyses. This is the Campbell analysis that you just saw on the previous slide, but now it's lying down into the page on the z-axis. So the x-axis has remained pressure in centimeters of water. Again, this is 0 atmospheric pressure. All the pressure down here is below atmosphere. All the pressure above here is above atmospheric pressure. This is functional residual capacity. It's diminished. And this patient will be breathing in this loop, inspiratory, expiratory, inspiratory, expiratory, and we'll go through this slide as well. So this is this rapid, shallow breathing during inspiration and expiration. So taking a look at the patient and their right ventricle in the patient with cirrhosis and ascites. Again, this is just cirrhosis and ascites. This is not discussing the effects of endotoxemia. These patients are salt and water overloaded, so their venous capacitance beds are full to the brim. So their mean systemic filling pressure is shifted to the right here. So this venous return curve represents an increase in their volume status. And then the right ventricular cardiac function curve tends to shift down and to the right. So this ghost venous return and cardiac function curve, this is the normal to which you compare. There's multiple mechanisms by which the afterload of the right ventricle is increased in the patient with ascites. This patient's atelectatic from the large ascites, causing compression of the lower lobes of the lungs. That increases pulmonary vascular resistance. It leads to an increase in this West Zone 4 physiology, whereby the interstitial edema within the lungs, the pressure within the interstitial space supersedes the transmural pressure of the pulmonary arterioles and causes collapse of the pulmonary arterioles, which would serve to further augment pulmonary vascular resistance. Hypoxemia leading to hypoxemic vasoconstriction. This alveolar interstitial edema essentially leading to hypoxemia and augmented PVR. Portopulmonary hypertension may be present as well. And this results in, again, the increase in afterload simply results in a somewhat diminished cardiac output. Again, this is blood flow on the y-axis. So comparing here to here, it's diminished, but it's occurring at a higher pressure as a result of the high right ventricular afterload. So during inspiration, right ventricular afterload increases even more. And so the increase in right ventricular afterload is denoted by this down and to the right shift of your right ventricular cardiac function curve. And so why does the right ventricular afterload increase with an inspiration? Well, we've talked about this as well. As you increase your lung volume above functional residual capacity, you tend to collapse the alveolar vessels, which augments the impedance to flow through the pulmonary arterial tree. And remember, dating back to Chapter 2, that impedance is a summation of both the overall cross-sectional area of a vascular tree, and that reflects classical resistance, and that's one portion of impedance. The other portion of impedance is this vascular reactance. And the reactance of blood vessels deals with the distensible blood vessels within the arterial tree and how compliant or stiff they are. And if they're very stiff, then that tends to increase reactance and therefore increase impedance as well. So in this patient, there's going to be an increase in the resistance to flow from increasing lung volume above functional residual capacity, but also, as you can see, that the distending pressure of the right atrium and right ventricle during diastole is greatly increased. Remember, the distending pressure is your CVP, which is here, or right atrial pressure. Here, the pressure within the vessel, less the pressure outside the vessel. And outside the vessel at this point, it's following this drop in intrathoracic pressure. So you can see that this RV is distended to a great degree. And well, that increases afterload because, as we talked about, by the law of Laplace, just simply increasing the radius of curvature tenses the myocytes, and that increased tension on the right ventricle results in a high afterload. And further, the high afterload is the result of an increase in the transmural pressure in the right ventricle and pulmonary artery, primarily as a consequence of an increase in the pulmonary vascular resistance, as I just talked about. But interestingly, and I think I talked a little bit about this in COPD and maybe a little bit in Chapter 3 as well, at least I should have talked about it in the section on COPD, because I think this is where the best hemodynamic data comes from, is that, and it's a bit of a circular argument, but it's kind of provocative, I think, and that is, as you increase the distending pressure of the right ventricle, right, the transmural pressure of the right ventricle, the distending pressure tends to increase the right ventricular volume as a function of right ventricular compliance. And as the right ventricle expands in volume, you get this ventricular interdependence effect where the compliance of the left ventricle is impaired. And remember that the RV, ultimately the back pressure to right ventricular ejection is the left atrial pressure. So simply by the RV expanding and dilating and compressing the LV, impairing its compliance, and then increasing your LV EDP, the RV is effectively increasing its own afterload as reflected back through the pulmonary vascular tree. So that's another potential mechanism by which the afterload of the RV is increased during inspiration. And then just the opposite occurs. Oh, sorry. One last thing I wanted to talk about. Remember that the venous return curve has shifted rightwards here, and that is as because as the thoracic volume increases, you tend to collapse, or not necessarily collapse, but compress the venous beds of the abdomen. And in the patient who's cirrhotic and volume overloaded, they're going to have a preponderance of West Zone 3, quote unquote West Zone 3 physiology as it applies to the abdominal venous beds. And therefore, as they are squeezed, that actually favors venous return to the right heart. And so that's going to further increase the filling pressure of the right heart and further augment the distending pressure of the RV. So then on forced expiration, essentially the opposite occurs. During expiration, as lung volume is decreasing, the afterload of the RV is attenuated. The cardiac function curve shifts up and to the left, and the venous return curve shifts leftwards because that bolus effect from the abdominal venous beds is diminished as well as lung volume is reduced. And note that, this is the pressure that you're measuring with your triple lumen catheter here, and it's high on expiration, but the actual distending pressure is actually quite low because the intrathoracic pressure, which is following the Campbell analysis on the z-axis here, the intrathoracic pressure is quite high. So this is the intrathoracic pressure here, and we're ignorant of this. Remember that when we put in our triple lumen catheter, we reference it to atmospheric pressure. So we were referencing it to this point, but we don't know anything about changes in intrathoracic pressure, so that can lead to measurement artifacts. So don't think that the high CVP in this situation means that the RV is distended. It just means that it's reflecting this augmentation of intrathoracic pressure. So let's go through the same thought experiment, and this time let's talk about the left ventricle. So again, rapid shallow breathing, inspiration, expiration. That was pleural pressure on the x-axis, as we just talked about. This is atmosphere, this is below atmosphere, this is above atmosphere, and this is lung volume on the z-axis going into the page. This is the pulmonary elastance curve. This is the chest wall elastance curve. You can notice they're both shifted down. This is from the ascites. This is from the poor pulmonary compliance, from the volume overload. And these loops here represent inspiratory and expiratory airways resistance. So now this is, again, blood flow on the y-axis, but this is now your pulmonary venous return curve, not your systemic venous return curve. This is your left ventricular cardiac function curve. This essentially represents the normal. This is your left atrial pressure, again, 0 above atmosphere, below atmosphere. And again, I've said this multiple times already, and I animate this in Chapter 7 when I'm talking about your wedge pressure, which is essentially what this point is here. It's like, the CVP of the left heart. That changes in intrathoracic pressure, the direct effects of the changes of intrathoracic pressure upon the wedge pressure is such that as intrathoracic pressure drops, both the pulmonary venous return curve and the cardiac function curve would actually shift in tandem leftwards with a decrease in intrathoracic pressure and rightwards with an increase in intrathoracic pressure. But it's not changing the two curves relative to each other, so it's actually not that is, the direct effects of intrathoracic pressure per se are not changing the distending pressure of the left atrium or the left ventricle during diastole. But other effects of changes in intrathoracic pressure and lung volume can shift the curves relative to each other. But for simplicity, I'm not demonstrating that shifting effect of these curves together. So this is the normal patient. Now this is the patient who's volume overloaded, so their lungs are all full of water. They're all West Zone 3, so the pulmonary venous return curve is shifted rightwards. And in this case I've illustrated a patient without any underlying left ventricular dysfunction, so they've got essentially a normal left ventricular cardiac function curve. And when the patient inspires, again, this is FRC, and this line here is the ghost of the right ventricle that we just saw. So as the right ventricle is pulled along with the drop in intrathoracic pressure and the right ventricle dilates, as I just spent quite a bit of time talking about, well, that dilation of the RV leads to this pronounced downshift in the left ventricular cardiac function curve. And again, that was due to the diminished compliance of the LV that occurs via left ventricular interdependence. And again, this higher filling pressure that occurs in the left heart can reflect back and further increase right ventricular afterload, as I just talked about. Now, the pulmonary venous return curve, like the systemic venous return curve, with an increase in lung volume. Remember, lung volume as it increases along the z-axis into the page. As lung volume increases, when there's a preponderance of West Zone 3 physiology in the lung, as you decrease the capacitance of those beds, you favor pulmonary venous return to the left heart, essentially like increasing the mean systemic pressure, but you're as you decrease the capacitance of the pulmonary vascular beds. The drop in intrathoracic pressure in and of itself afterloads the LV, as I talked about more in the section on systolic heart failure, so that tends to bend the left ventricular cardiac function curve down into the left. But you can see with inspiration you can have a pretty predominant drop temporarily in your left ventricular output. And then forced expiration kind of has the opposite effects. As the right ventricle shrinks with forced expiration, that ventricular interdependence effects is negated. LV compliance is improved. The increase in intrathoracic pressure tends to reduce afterload of the LV, so that there's a few different effects that are favoring shift up into the left of the cardiac function curve. And again, the pulmonary venous return curve kind of shifts back leftwards. And so there's less pulmonary venous inflow as lung volume is decreasing in this situation during expiration. And again, it is the relative contributions of the decrease in pulmonary venous return to the improvement in the cardiac function curve that determines the change in your left ventricular output during forced expiration. but there, as illustrated here, there can be significant respiratory variation seen here. So moving on to the next slide. Now we're going to talk a little bit more about sepsis and kind of go over some of that physiology again. So the effect of septic physiology upon the venous return curve is to shift it leftwards as blood volume is lost from the stressed portion of the venous capacitance beds. And again, as I use this sort of waterbed analogy, Sheldon Magner uses the bathtub analogy. But if you kind of make that waterbed more compliant and boggy, then the pressure that is generated within your venous vessels is actually diminished. And there's increased capillary filtration with sepsis, and if you have some hypoalbuminemia in the cirrhotic patient, then you may compartmentalize some of that fluid into the interstitial space, so you may actually lose intravascular volume. But again, typically that's that physiology is contentious. It's hard to quantify, and it tends to be. I think it tends to be more of a true physiologic problem only when there's very profound hypoalbuminemia. And I'm really citing no evidence for that last statement. There's a dramatic reduction in the resistance to venous return. So this is an interesting aspect of sepsis that. The resistance to venous return, you sort of think of it as like the floodgates for blood flow back to the right heart. And in sepsis, that tends to be diminished, so it actually favors blood rushing back to the right heart despite this diminished mean systemic filling pressure. And it tends to favor a high cardiac output. You can imagine as you have more venous return, you would, as long as your cardiac function is adequate, you'd be able to augment your forward flow. And so it's kind of similar to what happens when you go out and exercise. If you go out and exercise, there's a dramatic drop in the resistance to venous return. You have increased blood flow to the right heart, and this is partially mediated by, or largely mediated by, your adrenergic system, and it has to do with certain adrenergic receptors, particularly beta receptors, which tend to diminish the resistance to venous return, versus alpha stimulation, which tends to increase the resistance to venous return. But unlike exercise, the cardiac function curve does not also improve. So herein lies the problem with sepsis. So you're kind of bolusing the right heart from the septic physiology, opening the floodgates, decreasing the resistance to venous return. You're augmenting flow to the right heart, but the septic cardiomyopathy that can be seen above and beyond any of the patient's underlying comorbid cardiac issues can really stress the heart. And so the poor cardiac function that's seen in sepsis can sometimes explain the initially noted high right atrial pressure. This is a brief overview of sepsis in the Gaytan diagram. So if this is your normal with your mean systemic pressure here. This is your right atrial pressure, which is the intersection of the venous return and cardiac function curves. Here's the right ventricular cardiac function curve. This is kind of what happens during sepsis. As you lose volume from your stressed volume into the unstressed volume, your mean systemic filling pressure effectively decreases. But this dramatic reduction in the resistance to venous return really increases the slope here. So this, and as I talk about in Chapter 2, it's the resistance to venous return is defined by the slope of the venous return curve. And you can see that actually, in this situation, assuming a normal underlying cardiac function, cardiac output is actually augmented here. And that's because of the high forward flow. And this this low resistance for blood to return to the heart can result in these very large fluctuations in right ventricular output during inspiration and then expiration, as I just showed you. But that will be mitigated if there's severely impaired cardiac function. So if this patient has a very poor right heart function, or cardiac function in general, if they inspire and then expire, that fluctuation in right ventricular output will be diminished. So again, just going over that physio. This might be a little bit redundant, but we're going to go over that physiology that we just talked about in the previous slides. So this is the patient with the Campbell analysis, rapid shallow breathing, low chest wall compliance from massive ascites, low pulmonary compliance from pulmonary interstitial edema, high airways resistance on inspiration and expiration. Again, this is atmospheric pressure at 0 here, above atmosphere, below atmosphere, and this is your intrathoracic or pleural pressure in centimeters of water. This is functional residual capacity. And so as you inspire, oh, sorry, I'm not going to go through that thought experiment. Let's just superimpose. This is the normal venous return and right ventricular function. But this is cirrhotic endotoxemia, as indicated, as I'm sort of going through stepwise here. This is the, as we talked about, the right ventricular cardiac function curve. From this is normal to here. The right ventricular cardiac function curve is shifted down and to the right from all those problems that I talked about on the previous slides: atelectasis, hypoxemia, portopulmonary hypertension. If your wedge is high, that can increase your right ventricular afterload as well. They're salt and water overloaded, so as you can see, comparing this state to this state, the venous return curve is shifted to the right, so their mean systemic filling pressure is higher from that salt and water overload. The distending pressure of the right ventricle is high on account of both the impaired right ventricular function and the increased venous return curve. But then the septic physiology, as I mentioned, tends to change things just a little bit. You have a reduction in your mean systemic pressure, but an increased, or sorry, I keep saying increase, a decreased resistance to venous return, so it favors flow back to the right heart. And now what that does as you inspire is it tends to simply mimic the physiology that we talked about on the previous slides in terms of diminishing your cardiac output. There's an increase in your right ventricular afterload. It tends to favor filling of the right heart, right ventricular distension, therefore impaired left ventricular compliance via interdependence effects. And then forced expiration has a similar effect. Again, forced expiration, you remove that increased afterload on the RV as lung volume is coming down, as the radius of curvature of the right ventricle is being diminished because of a diminished venous return, so that further improves the afterload. And then the systemic venous return curve is shifted leftwards during expiration because as lung volume is decreasing, the capacitance beds of the abdominal venous tree is the stress is coming off that. The capacitance is increasing, and so there's less of a forward flow gradient for venous return. And similarly for the left heart, again, this is very similar physiology to the previous slides. But the pulmonary venous return curve is shifted rightwards because of the increased West Zone 3 physiology. Inspiration, again, this is the ghost of the RV, tends to distend the RV, which impairs the LV by compliance effects, so the LV curve is shifted down and to the right. Afterload is increased as the intrathoracic pressure is decreased. And pulmonary venous return is augmented as lung volume is increased. And then forced expiration tends to reverse those effects, as we talked about on the previous slide. So now moving on to mechanical ventilation of the cirrhotic patient. Again, we'll run through the Campbell analysis. Again, I call this the modified Campbell analysis because the x-axis refers to both intrathoracic or pleural pressure and airway pressure, depending on which curve you're looking at. Recall that the plateau pressure is measured at the proximal trachea, and that represents the static compliance of the entire respiratory system, the respiratory system being the lungs and chest wall together. And because of the dramatic reduction in both the pulmonary and chest wall compliance, as I've already talked about, the summative respiratory system compliance is severely reduced. And again, it's the summative respiratory system compliance that it's important to consider during mechanical ventilation, because that really determines what your proximal airway pressures are measured off of the ventilator. And this can be visualized on the Campbell analysis. So again, normal pulmonary elastance or compliance here, normal chest wall compliance or elastance here, and functional residual capacity is the intersection of the two. Intrathoracic or pleural pressure, it's not labeled very well, is on the x-axis, and on the y-axis is volume. This is 0 or atmospheric pressure, this is above, and this is below atmosphere. So what happens with the cirrhosis? Again, you have the reduction in pulmonary compliance, so that curve shifts down into the left, or shifts down into anatomic right, which sometimes sometimes when you're watching my videos, you may note that I have my left and right mixed up, and that's, again, I think I've mentioned this before, that's because my brain is sort of trained to think in terms of anatomic terms when I'm looking at chest x-rays now. So this is certainly the left portion of this diagram here. But if I say right, that means in my brain I'm thinking like this is the right lung when I'm looking at a chest x-ray. So I'm rambling again. What am I talking about? Oh yeah, lung elastance or compliance. The lung compliance is reduced. Functional residual capacity is reduced. And again, this increases this pressure that must be generated by the muscles of inspiration to achieve this volume. So this is volume green, and this is volume red, volume blue, volume dark blue. And that's, again, the muscles of inspiration that must generate that. So if you then throw on some massive ascites and dramatically decrease the chest wall compliance, well, the muscles of respiration are just going to get really tuckered out here. If they wanted to get dark blue volume, they'd have to generate quite a pressure. And so as we saw in the previous slides, these patients engage in rapid shallow breathing. But I'm talking about this because when the patient is heavily sedated and paralyzed on the ventilator, well, this pressure differential between the two also represents the amount of pressure that the ventilator must apply to achieve that volume. So if the patient's on a volume-limited mode of mechanical ventilation and you dial in volume red on your ventilator, whatever volume that is, well, this is, you're dialing in volume red. Well, the pressure difference between these two curves is the amount of pressure that you would measure during an end inspiratory hold on the ventilator, measured at the proximal trachea, and that's because this is the amount of pressure while it's the amount of pressure that must be generated by the inspiratory muscles to generate this volume. It's also the amount of pressure that must be applied by the ventilator at the proximal trachea to move both the lung and the chest wall together. So now if we were just to graph that, and this would be like how much pressure the ventilator would have to apply to achieve this volume versus this volume, this volume, this volume, you can appreciate that that's simply a line that describes summative plateau pressures for the respiratory system. So you can see that the respiratory system curve is quite, in terms of the compliance, is quite depressed. And so now this is your plateau pressure, as I mentioned. If you dialed in this volume red on the ventilator, well, this is the plateau pressure you would read off the ventilator. And this is your intrathoracic pressure, or your PPL is your pleural pressure. And again, it's somewhat high because in the sedated and maybe paralyzed patient that's not generating any activity in the muscles of respiration, so this chest wall compliance curve stays static. The pleural pressure or intrathoracic pressure follows the chest wall elastance curve, and that's because as the lung increases to this red volume, it pushes out against the chest wall, and the volume between, or the pressure that's generated between the lung and the chest wall, generates intrathoracic pressure. And so pleural pressure can be thought of as the delta lung volume over the chest wall compliance, and that's well illustrated by I don't know if it's mine, but the slides where I have the balloon in the box analogy. So running through that modified Campbell analysis, I've modified it even further. Again, the Campbell analysis, that lung volume is on the z-axis going into the page. Again, this is that modified pressure, pleural pressure or airway pressure in centimeters of water. This is 0 above atmosphere, below atmosphere. This is the curve of the respiratory system, and this is the compliance curve of the chest wall. And I've left out the diminished pulmonary compliance curve, which would sort of go track up here like that. I just left it out for clarity. And again, this would be functional residual capacity where they meet. So let's run through an experiment where we apply PEEP to the patient. Well, as you apply PEEP, the lung volume is going to increase and press out against the chest wall compliance curve, and the intrathoracic pressure that's generated will be a lot higher because of the diminished chest wall compliance. So that would tend to have more of a preload effect on the right ventricle. Okay, so now the reduction in the respiratory system compliance curve, which is due to both the chest wall and the lungs, results in an increase in your airway pressure, or sorry, I'm getting a little bit ahead of myself. So that was the application of PEEP. Okay, now if you were to apply a breath on top of that, then the lungs would expand, up the z-axis here, so from here up to here, and your intrathoracic pressure would raise to this level here. So that would be a breath on top of PEEP. But what I was getting ahead of myself was that the airway pressure that you would measure on the ventilator would actually be would follow this curve. So this curve here represents the airway's resistance that the ventilator must overcome to push gas into the lungs, and then the static compliance curve of the respiratory system. This denotes the pressure that must be applied by the ventilator to maintain a volume of both the lungs and the chest wall together. And you can see that this airway pressure is quite high, and that's because of the diminished compliance. And as I talked about in the ARDS section, this represents at the end inspiration, an end inspiratory hold. If this is your airway pressure out here, well, the end inspiratory hold at your proximal trachea essentially creates, it's like a wedge pressure of your alveoli. It creates a static column of air all the way down to your distal alveoli, and that's negating any of the occult PEEP effects that I talk about in the last section of Chapter 1. But assuming all of your airways are open and patent all the way down to your alveoli, the proximal pressure that's measured off the ventilator during an end inspiratory hold is essentially an approximation of the alveolar pressure, and the alveolar pressure less your pleural pressure or intrathoracic pressure. Well, that difference is that's your transpulmonary pressure, and that is your right ventricular afterload. So again, because of the diminished chest wall compliance, the increase in intrathoracic pressure tends to decrease the transpulmonary pressure, and therefore that tends to lower the right ventricular afterload. So in effect, the massive ascites, which diminishes chest wall compliance curve, results in a higher than predicted intrathoracic pressure, and that actually therefore reduces your transpulmonary pressure, and your right ventricle actually kind of likes that. And there's a group in France that has modeled this with patients with bad, I don't think I talked about in the ARDS section, but in patients with bad pulmonary ARDS, where the transpulmonary pressure is quite high because the diminished respiratory system compliance is being driven entirely by the diminished pulmonary compliance, which, as I talk about in the ARDS section, greatly increases your transpulmonary pressure. Well, that high transpulmonary pressure results in a high RV afterload. And so what this group in France does is they've shown that if you then bind the chest, which diminishes the chest wall compliance, you therefore effectively increase your intrathoracic pressure, decrease the transpulmonary pressure, decrease the right ventricular afterload. And looking at the velocity time integral, which is a surrogate for stroke volume across the pulmonic valve, they've actually shown that it actually tends to augment forward flow of the right ventricle. So that's kind of what the ascites is doing for this patient. So now superimposing the Gaytan analysis, again, we've talked about this. This is your measured right atrial pressure, or CVP. This is your intrathoracic pressure, which corresponds to your functional residual capacity. So if you intubate this patient and then apply PEEP to the patient, well, then the right ventricular cardiac function curve will shift rightwards like that along the intrathoracic pressure curve. It's not really the intrathoracic pressure curve, but it shifts along the x-axis in response to the increase in intrathoracic pressure. Tends to diminish the distending pressure of the RV. Again, that's the preload effect that you get. PEEP also alters the venous return curve, as I talked about in a number of sections in these lectures, in that it increases the P crit, or the pressure at which collapse of the great veins occurs. And again, you can see that the venous return curve is shifted somewhat rightwards from here to here as a result of pressurization of the abdomen. And there's a greater increase in this patient because this patient's abdomen is predominantly in West Zone 3. So the septic myocardium, in addition to the high transpulmonary pressure, elevates RV afterload and ejection is reduced. The high pleural pressure, what have I written here? Well, I guess what I've alluded to here is I'm saying that the transpulmonary pressure is kind of elevated. Again, this just goes to show you that these slides that I've made are very, you can bend the physiology in multiple ways. And, again, the transpulmonary pressure here is going to be dependent upon the relative difference between the drop in respiratory system compliance and chest wall compliance. So if this patient's chest wall was very low from the massive ascites, well, then the transpulmonary pressure would be even lower. It's all, it's kind of a titration. So here I'm saying, the septic myocardium has diminished the right ventricular cardiac function curve. And, this transpulmonary pressure, which is high because of the diminished respiratory system compliance relative to the chest wall compliance, tends to impair RV ejection, but the increase in intrathoracic pressure from the PEEP effect tends to shrink it. So again, it just goes to show you that in patients like this, it can be very, very difficult to explain their physiology. And I've certainly been in this situation multiple times in the intensive care unit where you're doing these interventions and you're just trying to think of reasons why patients are behaving in the hemodynamically as they decide to behave, and sometimes you can just sort of be left scratching your head. But you need to realize that, at least I hope these lectures help you realize, is that there's many, many moving parts in these patients, and it can be one can become quite conflicted. So the breath on top of PEEP, then again, I have not illustrated. I've left the venous return curve kind of static here. Again, I think I did that because I just ran out of room. But again, as you increase lung volume on top of the PEEP here, I think this is what I'm trying to say, this tends to augment the transpulmonary pressure and drop the right ventricular cardiac function curve down into the right. The venous return curve would technically shift rightwards a little bit and defend cardiac output, which I have not illustrated, but just be wary that would occur, that as you increase lung volume, you pressurize the abdomen, you compress the blood vessels, and in this anasarchic patient, that would actually favor squeezing blood out of the abdominal venous beds back to the right heart. But in this patient, I think what I was trying to say previously was that the application of PEEP, because of the shapes of these two curves, the application of PEEP, that's a steady state effect. And this here, the pulmonary pressure with the application of PEEP is actually fairly low, so there would be less afterload effect, more of a preload effect, and that would be a steady state effect because PEEP is present with every breath. But then with each subsequent breath above PEEP, well, the transpulmonary pressure is increased because of the reduction in the respiratory system compliance out of proportion to the reduction in the chest wall compliance. So the breaths on top of PEEP can actually have a different physiology in terms of afterload in comparison with the steady state effects of what PEEP can do to right ventricular preload and afterload. So the same physiology with sepsis in the left ventricle. Well, the application of PEEP increases your intrathoracic pressure to a greater degree because of the diminished chest wall compliance. And then the breath on top of PEEP further increases intrathoracic pressure. And then the increase in airway pressure would be seen like that. And again, bear in mind, maybe I was a little bit less clear in the previous slide, that PEEP is I've said this before, a steady state effect. So this is a new physiology that is present throughout the respiratory cycle. And in this patient, it results in essentially a preload reduction by shifting the RV cardiac function curve rightwards with minimal RV afterload reduction. But the intermittent breaths that you get in a cyclical manner above that PEEP results in both with a preload effect and a more pronounced afterload effect. So again, this can go to show you how the physiology can be varying on a breath-to-breath basis. So how does that affect the LV? Well, I've drawn the LV cardiac function curve down and to the right because of septic physiology. The application of PEEP may or may not improve its function. It depends on whether or not the RV is dilated or if it shrinks. let's just run through the breath, right? So this is a steady state effect as you apply PEEP. And in this situation, I've indicated that the diminished volume of the RV has improved left ventricular compliance via diastolic ventricular interdependence effects. So the left ventricular cardiac function curve is shifted up and to the right. Also, the venous return curve, I've demonstrated, is shifting somewhat to the right because of the increase in lung volume tends to decrease the capacitance of the pulmonary vessels and increase the pressure head for pulmonary venous return back to the left heart. And then with subsequent breaths, as the right heart changes in size, whether the RV preeminently shrinks as a result of preload effect with an inspiration, or if the RV dilates as a result of an RV afterload effect, well, that will have opposing effects on the compliance of the left ventricular cardiac function curve. But the increase in intrathoracic pressure that you get because of the poor thoracic compliance, that would tend to favor an up and to the left shift of the left ventricular cardiac function curve because of afterload effects. And that would be most apparent in patients who have a cardiomyopathy. And in this patient who may be septic, if they've got poor cardiac function on account of impaired LV inotropy, well, then increasing intrathoracic pressure may actually facilitate cardiac function. And then on expiration, you tend to reverse that physiology. And so the pulmonary venous return curve shifts leftwards on expiration as lung volume decreases, but left ventricular cardiac function curve may be impaired, again, by the decreasing intrathoracic pressure, which would tend to briefly afterload the LV. And again, if the right ventricle dilates during expiration, to the extent that the RV dilates, again, the RV may dilate during expiration because as intrathoracic pressure is diminished, it tends to favor preload augmentation to the right ventricle. To the extent that the RV is dilated, you may actually also worsen left ventricular cardiac output, left ventricular compliance, and shift it down into the right by interdependence effects. So that's it. That's the end of Chapter 4. Again, just want to reiterate that the disease states that I presented, and I think are far from textbook. None of them ever follow the same path. There's many moving parts. There's many conflicting physiologies in terms of biventricular preload and afterload, in terms of changes in intrathoracic pressure and volume. And the point of these slides and going over these various disease states is to give some general principles of cardiopulmonary interaction in the intensive care unit, and how PEEP can impart steady state effects upon the cardiovascular system, and then spontaneous ventilation or intermittent positive pressure ventilation can then impose transient effects on the cardiovascular system that can result in dynamic increases and decreases in cardiac output. And that will have a little bit more relevance to Chapter 8 as I talk in more depth about dynamic means of cardiovascular monitoring. So thanks for tuning in, and it's really been a pleasure. See ya.